So now you see a picture of people kind of scrunched over, looking like they are in pain or something else. Pain is always a difficult experience, and that's what we're trying to show here. But it is especially difficult for many people with developmental disabilities. I want you to stop and take a second or two and just think about a pain that you have felt at some point in your life. I doubt there's any of you who haven't felt pain somewhere along the way. Was it visible? I'll give myself as an example. I have sinus pain as a continuous chronic issue for myself, and it's inside my head. There's no big sign across my forehead that says pain, pain. It's not seen. All caregivers need to consider if a person could be in pain when behavior changes. For some individuals, asking if they are in pain is a start. Some people can utilize that pain scale that you have available to you that I provided, either using the numbers or using the faces. But for others, that is not going to be helpful either. Others are just not able to understand it. I'm going to use real examples of people throughout these hours together. And please understand that the names have been changed. So when I tell you about George, that's not his real name, but it is a real story. George was a client I was working with who began crying and yelling and was no longer able to sleep well. When his team approached me with concerns about this, we tried to find possible things that could be an issue. Finally decided he needed to go into the doctor, and they couldn't figure it out either, and they did x-rays. To all of our surprises, he had a broken hip. Here he was, still walking and functioning, but not well, with a broken hip, which would have been excruciatingly painful. And it wasn't until we went to that level of seeking out what was wrong that we came to that discovery. Well, now the cursor thing is not working. Yeah. Oh, there we go. Sorry. We're continuing to have glitches, but we'll do our best. Okay, so many people with developmental disabilities cannot use the words to tell us about pain, even if they are verbal sometimes. But many are nonverbal and they show disruptive behaviors. And if we were in a classroom together, I would be asking for examples of what you have seen. If you see a blank face, is the person in pain? Maybe, but maybe not. So you have to look for the other clues such as movement, restlessness, screaming, crying, eating changes, sleeping changes, and aggression. Sarah was in the hospital with a broken vertebrae in her neck. We knew she had the broken vertebrae, and she was frequently laughing loudly. A wind nurse came there and asked if Sarah was being given pain meds, and the nurses responded by saying, well, no, she's happy. However, it was clear to us that no person would be without pain if you had this broken vertebrae. Laughing was her way of expressing pain. So when given pain meds, the laughing stopped. Because pain has such a great effect on quality of life, it is important for caregivers to be aware of and treat conditions that cause pain. We don't expect you to be nurses or doctors. What this whole PowerPoint is about and webinar is to help you to be aware of possible causes of pain. And there are things that can be done at home, and then there are times when you must go into the doctor and make sure the doctor understands what might be going on. So we're going to look at the possible causes from top to bottom. We want each of you to be painfully aware. Starting from the top with headaches. There are pain, guess what, in the head or the scalp or the neck. Can be many different kinds of reasons that are relatively simple, like diet or not getting enough to drink, sleep, stress, tension on muscles, side effects of medications, or due to serious things such as tumors, brain infections, strokes, and brain aneurysms. Headaches, behaviors. What do you see with headaches? You might have had a headache yourself, and you may think about that. We see very commonly agitation and behavior dysregulation causing aggression. Um, Head banging is a common behavior. Some of these others you'd be more likely to think about: furrowed brows, squinting eyes, what you see with the pictures here. Um, Avoiding bright lights and loud noises um, are also good clues. And of course, verbalization of pain. As far as I know, nobody likes to document. But I'm telling you right now, if you don't write down what goes along with the headache, the clues will be lost. So note the time it occurred, note how long it lasted, write down factors that may have triggered it if you suspect foods, or there's been a stress or a change in the sleep pattern. And then the bottom one is very important. Notify doctor if the headache occurs with a fever, neck stiffness, nausea, or with a head injury. If there's been a fall, that should never be ignored. That is something you must go pursue with the doctor. So headache treatment at home, rest is often good. Darkness is often helpful. Buy water, juice, or beverage for good hydration. Rest a cool or warm washcloth on the head or neck, whatever a person tolerates and finds comforting, and give an over-the-counter med such as aspirin, ibuprofen, or Tylenol. If a person is prone to headaches, make sure you have the PRN, meaning as needed medication, available at the home. And if a person is living in a residential setting that requires a doctor's prescription for the medication, even though it is over the counter, be sure to get an order. It should state clearly what dose should be given and how often it can be given. Sinusitis, all the stories I could tell about sinusitis. It's a sinus inflammation. And you see here on this picture, the sinuses above and below the eyes. You can feel pressure and pain from that, or you could get a sinus infection from bacteria that collects in the mucus there. Again, a list of different things that can cause it. Viruses, allergies, that's the bane of my existence. Cystic fibrosis, smoking, or poor immune function. If perchance you have someone you work with or yourself that has a CAT scan for other reasons, you're not going to get it for sinusitis, be sure and ask about the sinuses that show up on the CAT scan and whether there's any indication of inflammation or ongoing challenges. Sometimes that's how we find out for sure that somebody has problems with their sinuses. The doctors aren't going to remark on that if they're looking for other things, but they can tell you what they see if you ask. So, what are signs of sinusitis? The things you may be aware of are bad breath, hands or fingers in the mouth, cough, fever, nasal congestion, or discharge. Symptoms, things you might not notice, are things like being tender. You can tap gently with the pads of your fingers over the sinuses, and the person may respond by moving backward or making a vocalization or hitting you, and you'll be aware that that is a tender area. A decreased ability to smell, sore throat, headache, and fatigue. Another sign that I often ask when somebody is reporting to me that they're having trouble with a person waking up in the late night or early morning is that can be a sign of a sinus headache. As a person lies down over a period of hours, mucus builds up in the sinuses, and there can be more pressure and more pain that wakes you up with a bad headache. All right, what can you do about sinusitis? Well, you can place a warm, moist cloth on the sinuses several times a day. You can also run shower water on the sinuses when you're in the shower. Drink plenty of fluids to thin the mucus. Inhale, it says steam, and I really should change that. We're talking about the warm mist. Inhale warm mist from a shower. Use a humidifier. Use a nasal saline spray, which you can squirt directly up into the nose, or a neti pot, which we have a picture of here, where you've got to tip your nose and your head and put it in one side and it comes out the other. Probably something that you really have to be committed to doing, but it can be very helpful. Tylenol or ibuprofen for pain. And then again, the last one, if it lasts a long time, contact a doctor. A person may need antibiotics for a sinus infection or antihistamines for allergies, which will help prevent the allergic buildup of mucus in the sinuses. Okay, ear problems. What's the behavior we see? Again, we've seen head banging. We've seen hitting or pressing on the ear. Aggression, crying, sleep problems, changed response to noise, and loss of balance. Have you ever had an earache? It is an intense pain. Ear pain and pressure in the ears worsens when you lie on that ear at night. So that could be another reason that a person would wake up in the night. I love this picture. Here you can clearly see the ear, and you can see what they call the tympanic membrane, which is the medical name, commonly called the eardrum, that shiny white spot there. And you can see a tube going downward, and that's where mucus can come in there after a cold or a virus. And that's often when you have an earache and an inner ear infection right in here. That eardrum won't look shiny and white, it'll look red and bulging. And you can have an outer ear infection. Or you could have wax buildup or just plain fluid pressure. So treatment includes assessment by a doctor and the necessary medications. If you have an inner ear infection, typically antibiotics, so they may be more hesitant now than they used to be about that. Ear drops may be used for an outer ear infection, and people are less familiar with that. If you are a swimmer and you swim every day and you're not careful to dry out your ear after swimming, you certainly can get a yeast infection of the outer ear. I have also had a situation or two. I'll mention Bill. Bill was having a recurring outer ear infection, and it was a regular ear infection with bacteria. Finally, I asked, does Bill keep his fingers clean and his fingernails clean? And does Bill stick his fingers in his ears? And I got a no to the first one. He was challenged with not necessarily washing his hands, and he wasn't very careful when he was cleaning himself after having the BM, possibly even sticking his fingers in his anus sometimes. And so there was definitely a concern that his fingers were contaminating his outer ear canal. And when they made an effort to make sure that that didn't happen anymore, somebody was always watching to make sure his hands were clean, they kept his fingernails shorter, he stopped having outer ear infections. So that's something you might not have thought of before, but it is always something to be aware of. Another client began yelling and hitting her head, and finally took her to the doctor. Actually, not finally, but we got an appointment, got her in. It didn't need to go to the ER. And when they looked in her ears, they were just full of wax. And once that earwax was removed, the dysregulation of the behavior stopped. So an additional medication for her was ear drops that she has every month to prevent wax buildup. People sometimes have decongestants just for ear pressure as well. Oral disease. Oral health problems can include cavities, it can include broken teeth, gum disease, which is called gingivitis, and thrush, which is a yeast infection. Oral diseases can include the gums, the teeth, and the teeth sockets. Oh, here we have a beautiful picture. Well, no, maybe just for a nurse, a beautiful picture, but a very good picture of yeast in this person's mouth. So signs of oral disease can include swelling, bleeding, swollen, bright red or purple gums, mouth sores, or this white coating on the tongue and inside of the mouth, which is from yeast. It's called thrush. Behaviors, what might you see? Hands or fingers in the mouth, activity, restlessness, head banging, refusing food, trouble chewing, and sleep changes. Betty was refusing to eat. And she pushed people away if they tried to look at her mouth. So we were wondering what was going on. So finally, in exasperation, I stood in front of her and I stuck out my tongue. Blech. And she stuck out her tongue in response. And it looked just like this tongue, only even worse. The whole tongue was coated with white, thick stuff. And then we had the answer. She had thrush. So she had to have medication for thrush. And then she began to eat again. I will admonish, it's something we tend not to think about, but mouth sores, any open area in the mouth, are an open door for bacteria to spread to the rest of our bodies and especially the heart. So if we are concerned about mouth sores, we need to be concerned about its impact in the whole body. What do? Treatment and prevention is key. I know it's not easy. Many people find it intrusive to have somebody helping them with brushing. And if you get to flossing, that's a whole other ballgame. I'm going to be very impressed. Mouthwash is only useful for those who are not going to choke or gag or swallow it and perhaps even get it in their lungs. For people who have diabetes, you need to use extra caution, because if the blood sugars are too high, that really escalates the possibility of infections and sores and teeth cavity. So another thing for all of us, whether we have diabetes or not, is to reduce the amount of foods and drinks high in simple sugars. And remember, soda or pop, whatever you want to call it, Pepsi, Coke, they are high in sugars and acids. So they're a double whammy against our teeth. And then make regular appointments with a dentist. Again, I know that's not necessarily an easy thing. It can be very difficult to get dentists for people who are on MA. So you really have to work hard. And you can contact me if you have a desire to know about a few people. I have a few dentists that I know that will do dental care under anesthesia, and that's very hard to find. Power toothbrushes or musical power toothbrush can be helpful for some people to be willing to get their teeth brushed. It can result in a much more thorough toothbrushing. Also do gradual efforts. So you may not be able to be thorough at first, but if you can at least get in the mouth and then have some sort of reward afterward, you can gradually progress to having daily or twice daily toothbrushing. Sugar-free gum also has a positive preventive effect on teeth. Be aware, though, that this sugar-free gum is sweetened with xylitol, which is a mild laxative. So if you have somebody who's more likely to have loose BMs, you have to watch out. I had one person who had terrible diarrhea until I found out that he was chewing 6 packs of sugar-free gum a day, and that was a real problem. Sore throats. Many of us have probably experienced a sore throat. We've got a great picture here of the redness at the back of the mouth and down the throat. Again, possible various problems. Flu, gastroesophageal reflux disease. We usually say GERD, as you can guess why, because it's a long name. Strep throat, allergies, and tonsillitis. Usually inflamed, raw, scratchy, and irritated. What might cause a sore throat? Well, allergies are a key cause, and here are some of the things that you will see with allergies. Congestion and a runny nose, watery or itchy eyes, coughing, sneezing, itchy inside the nose, throat, and ears. Behaviors you might see are scratching, decreased eating, swallowing frequently. Remember, allergies can also cause sinus problems and then drainage down the back of the throat. So what can you do about it? Fluids, soothing drinks like tea, medications such as Claritin, Zyrtec, Benadryl, which makes you sleepy, but it's also an antihistamine, and throat lozenges. I often recommend throat lozenges because if somebody can tolerate those, won't choke on them, that's a way to have something soothing in the throat while they're temporarily having a sore throat from a virus, and it doesn't cause any other factors of side effects. Sore throat from strep. Signs and symptoms: fever, swollen lymph nodes, those are often, you'll feel them in the neck, a headache, and here we have a picture of the white and yellow spots on the tonsils of the throat. To prevent sharing strep, use good hand hygiene and make sure a person's sneezes and coughs are covered. Treatment includes making an appointment with a doctor so the person can have antibiotics. A person needs antibiotics for strep throat. Okay, I'd mentioned GERD previously. It is definitely a source of pain. It occurs, and again, we've got a nice picture, when stomach contents, including food, fluid, and acid, go back up into the esophagus, irritating the esophagus and the throat. We commonly cause it heartburn. So as you can see in that picture, there's a diaphragm and there is a sphincter. And so the sphincter is supposed to shut the door. But unfortunately, for many people, that it doesn't stay shut. So it can be caused by certain foods, medications. A lot of side effects from many meds include GERD, obesity, and positioning after eating. What are the signs and symptoms? We just talked about heartburn, burning in the throat and chest. It's increased by lying down or bending over. Regurgitation, often a little bit of food and fluid coming into the mouth, and a person may spit it out or drool it out, and people are worried that they're vomiting when actually it's from the GERD. Coughing, wheezing, hoarseness, a sore throat, recurrent pneumonia. Those are often missed and not recognized to be from GERD. A person can be misdiagnosed as having something going on with their respiratory tract, with asthma, when really it's from GERD. Recurrent pneumonia is when acid comes up and then it's aspirated into the lungs and it causes pneumonia. Dental erosion, a picture you have here, nausea, and losing weight if a person is not eating because of the pain. So, what might you see? What kind of behavior changes? Change in diet, refusing food, eating less, breathing difficulty, sleeping less, placing fingers or hands in the mouth. Acid often will come up in the esophagus and into the throat and mouth as a person is sleeping. So if a person wakes up in the first 1 or 2 hours after going to sleep, be suspicious, be aware. GERD may be the cause. Treatment. What to do to prevent GERD? Diet changes. It may vary by individual, but in general, smaller meals, eating slower, and avoiding these foods. These are the likely culprits, typical culprits at least. So you can see them and then think about then pizza, because pizza has spicy and it has tomato and other kinds of, so lemonade, for instance, coffee, are all possible culprits. What else can you do then besides avoiding the foods? Correct positioning. Maintain an upright position after eating. I encourage that for at least an hour, a half hour minimum. Avoid food 2 to 3 hours before sleeping and lying down, and raise the head of the bed during sleep. So an easy way to raise the head of the bed if you don't have a hospital bed is to either use risers under the feet at the head of the bed, or to put a folded up comforter under the mattress at the head of the bed. What else for GERD? Well, there's medications. Over-the-counter antacids can be used after meals. Those are either a liquid or a chewable tablet. And a physician can prescribe medications like Pepcid, ranitidine, Protonix, and Prilosec. Omeprazole is the generic name of Prilosec. Can also be used. Many of these are also available over the counter. But look at prescriptions that have GERD side effects. So if this is something that we have seen over and over. A person may have been prescribed medications, and then they were prescribed omeprazole because of the side effects of the medications. So sometimes medications that are on a list continue to be ordered, and they either didn't work or they're no longer needed. And if that's the case, a person may not need the GERD medication either. So it's important to consider this and ask the doctor about it. Proton pump inhibitors, which include Protonix and Prilosec, can decrease acid in the stomach enough that over time they can cause poor absorption of vitamin B12 and calcium, and that can result in deficiencies of both, which are not a good thing. So another possibility for somebody who has been on omeprazole or another proton pump inhibitor is to switch to Pepcid or ranitidine, which are the H2 blockers. And they don't have nearly the problem that proton pump inhibitors might have over time. Wow, chest pain. This is a dramatic kind of pain that probably we're all aware of. I put cardiac on there. Hopefully you all know that is the heart of things. So what are the symptoms of a heart attack or chest pain? Pressure, elephant on the chest, sharp radiating pain, the left side of the chest to the left arm, the neck, the back, or the jaw. And less dramatic are sweating, shortness of breath, and nausea. Those last three are more typical for women. So for women that you work with or for yourself, be aware that you might not have the dramatic pain, but you may have sweating, shortness of breath, and nausea, and it could be from a heart attack or from other heart issues, and it should not be ignored. What needs to be done? Follow a protocol for medical emergency. Give one aspirin and chew it if possible. If a person already has a cardiac diagnosis, follow the cardiac protocol, which often includes taking nitroglycerin under the tongue. So remain calm. Now that's a tough order, I know, but it is extremely important. You want to remain calm while reassuring the client and getting them by. Often this is a call for an ambulance. This is a 911 call, and you get them into the ER. Chest pain other. There are many other kinds of chest pain, from having a panic attack, from having gas in your esophagus and it hurts, or from having GERD. But you cannot ignore chest pain or pressure unless you know the cause. And you can't presume you know the cause. Now, for some people, if there's a known plan by the doctor for chest pain, heart issues have been ruled out, you follow that plan first. For example, Annie, the ambulance lover. She loved to go to the ER, and she loved the ride in the ambulance. So she was prone to complaining of chest pain when she didn't have it. And she knew that would work. So finally, we did get a plan in place from the doctor because she'd been checked out over and over. So she was given an antacid first when she was complaining of chest pain. She was redirected to something she liked to do, and she got personal attention from her caregiver plus a back massage. Wasn't the same as the ambulance in the ER, but it was enough to prevent a lot of ambulance trips. Constipation. Now, I'm just going to touch on constipation in several slides. I do want you to know we see constipation as a crisis over and over for people. We have webinar already done that's available on the COW website called Go With Your Gut. And it talks about your whole gastric system, including quite a bit on constipation. So just touching on it here, it occurs when bowel movements become less frequent or hard to pass. This poor man is really struggling here. If there is no bowel movement in 2 days, check if a person has a bowel protocol for how to treat it. A bowel protocol is a plan that we commonly help work on with teams and residential setting. If this is a family situation and it's your child, you need to work on having a plan. It can have very serious side effects, and it can have very serious consequences long-term on your colon. So what do we see? Things you probably are familiar with, but just briefly: straining, less frequent bowel movements, abdominal pain, stomach pain, decreased appetite, lethargy or agitation. I have been knowing people, and you might too, where when they have pain, instead of becoming agitated, they just sort of close down, get real quiet, try to sleep, and that's how they cope with pain. So be aware of that. Fecal odor on breath, nausea or vomiting. I know, you probably don't love this picture, but if you had come to a class in person, you would see candy equivalents of all of these. So you can probably know that at the top, those hard little lumps are a sign of constipation. So in addition to not going, if they just do these little bits of lumps, either in a toilet or in a diaper, you know they are constipated. And if those lumps in type 2 are just kind of stuck together, that's not quite as bad, but it is still a sign of constipation. All the way to the bottom, type 7, watery, I want to warn you, if you see this liquidy stuff and a person has not had a BM for a long time, this is not diarrhea. Instead, this is fluid leaking around a hard mass of stool in the colon. We've had bad experiences. Joe had this watery stuff, and his team called the doctor and said he had this watery stuff, and the doctor said to give him something for diarrhea. And he ended up, poor Joe, he ended up in the hospital. Because if you give something for diarrhea when a person is already impacted, you're going to have a very serious problem. So pay attention. If somebody has diarrhea, they're going to be having regular stools, and then it's going to become looser and looser. Know the difference. What do you do? Increase physical activity, increase fluids. Notice fluids first, and fiber in the diet. Do not give more fiber without giving more fluids, or it's going to make the problem worse. Change the toileting schedule to increase frequency. Hot drinks. Hot drinks are great. Herbal teas are wonderful. Avoid black tea. That's what's called regular, like Lipton's tea, if a person is constipated, because it has an ingredient in it that worsens constipation. Use a small step stool, it's called a squatty potty, in front of the toilet to raise the legs up, and that helps a person push better. Other treatment. Deep breathing while on the toilet to relax. Schedule time after meals for the person to sit on the toilet. And allow a person to have some time and to have maybe something that they can look at or do while they're sitting. Follow the protocol or plan in giving correct medications, including stool softeners, laxatives, suppositories, or enemas, and document and report as required so you know if a person is going or not. For most people who have a lot of medications that cause constipation, who have had chronic constipation, trying to fix it just by more fluids and more fiber is probably not going to be enough. So we do need to take it seriously, and a person needs medications if they're not going. Stomach ulcer. Oh, I like this picture too. Look, what is a stomach ulcer? Inflammation, erosion of the stomach or the duodenum. But you can see it's a raw spot. It can be caused by bacteria, the H. pylori, in which case you'll get antibiotics, alcohol, ibuprofen, aspirin, naproxen, and tobacco. So high acid in the stomach and those over-the-counter meds can be problematic. How do you find out? Well, first of all, one thing to do is lab work to check for anemia, which happens when there's blood loss. Check the stools to see if they're black or bloody, and have an endoscopy. That's a tube that goes down the esophagus and into the stomach. It looks at the esophagus, it looks at the stomach, and it might go down as far as the duodenum to look for an ulcer there. But before that, what gives you an awareness that it might be a problem? Nausea, vomiting, pain with eating, clutching and rubbing the stomach, changes in eating or drinking. I've often seen people want less, but I've had a few people who've wanted much more. It's like they wanted to keep drinking a little bit all the time to kind of soothe it, maybe cold liquids. Chest pain, weight loss, bloody or tarry stools, agitation, or fatigue. Here we have the black tarry stool. That's an indication of bleeding in the stomach. And there's the redness. Sometimes people are vomiting red, and we'll get to that. So treatment, again, medications, we've kind of already got into detail about these medications. Seek immediate medical attention. Again, this is a 911 call. If there's a sudden sharp pain, a rigid hard abdomen, and symptoms of shock, which would include being pale, sweaty, and confused, because you could be having a hemorrhage in the stomach. Arthritis, not nearly as dramatic, but it certainly can impair a person's ability to enjoy life. So here again, we've got some pictures. It occurs with a breakdown of cartilage between bones at the joint, causing inflammation, pain, wearing, and rubbing. In the center, you can see that rubbing right there of bone on bone. It can be caused by an infection, wear and tear, a previously broken bone, and autoimmune disease, commonly called rheumatoid arthritis. Septic arthritis can occur when an infection in the bone travels to, or when an infection in the body travels to a joint and infects it, and then it's very difficult to treat. The most common kind of arthritis is osteoarthritis. And so let's talk about the signs and behavior. Signs are, they don't want to do the things they used to do. They rather sleep more. They might gain weight because they're not moving around, or they're walking with a limp. Pain, swelling, redness, and warmth around a joint, stiffness and limited range of motion, that's very common, and deformity of the joint. The deformity of the joints are not nearly as commonly seen as the other things we talked about, especially the stiffness. Rheumatoid arthritis, you are going to have the deformity. Most people over age 60 have the beginnings of osteoarthritis in their joints. And the stiffness and pain is worse with the initial movement. It lessens as a person continues to move the affected joints. Elmer was a person who used to like to walk, but now he was refusing to go on walks. What he wanted to do was very reluctantly get to his feet, go slowly to his recliner, and that's where he wanted to stay. When we found out about this, we were pretty sure it was arthritis, osteoarthritis. And so after his meal, he had some ibuprofen. And then he was encouraged to walk an hour after he had the meal and the ibuprofen, and slowly he began taking walks again. He needed encouragement still with the initial movement. Pre-treatment of pain encourages willingness to move and exercise. So here we go. Exercise, as I said, to decrease pain and stiffness and increase muscle and bone strength, which helps as well. Heat or ice, splints, massage, assisted devices like that cane, maintaining a healthy weight. Unfortunately, the more we weigh, the more pressure we have, especially on our knees, ankles, and feet. Over-the-counter pain meds, NSAIDs, remember, we have to be careful, never on an empty stomach. If a person has any challenges with GERD or ulcers, you can't give NSAIDs. That is the naproxen, the aspirin, the ibuprofen we talked about. Or prescribed medications, especially for people with rheumatoid arthritis. They are going to be on steroids and immunosuppressants. Osteoporosis. Again, this picture shows it. The thinning and loss of bone density, and it can be caused either from a lack of new bone being created or too much bone being absorbed. Causes, aging is a big one. Extended bed rest is a big one. Not bearing weight. So somebody being in a wheelchair, for instance, because of their developmental disability. Insufficient dietary calcium, chronic diseases, medications, and seizure meds are right up there. Vitamin D deficiency and eating disorders. I really do need to explain that people who are on seizure medications, whether for seizures or for behavior issues, it drives down their vitamin D level. And if you have low vitamin D, you're highly at risk for osteoporosis. So symptoms: bone pain. The woman I mentioned at the very beginning, Sarah, with the broken vertebrae in her neck, had osteoporosis. So back and neck pain with fractures, fractures with little trauma, loss of height, stooped posture, as you see here in this older woman. Behavior signs, again, decreased activities or hesitancy to do activities, immobility, guarding limbs, rubbing or holding limbs, increased weight, and increased time sleeping. Geraldine was a person where she went to a MARC program, and her daily routine was to get up out of a wheelchair, which she used to get there, and she would get up and walk around at the facility. But the staff were saying she just won't get up anymore. And they asked the wind nurse to come, and he came, and he recommended an x-ray of her spine, which showed broken vertebrae in her back. And that is very painful, and it hurt less if she just stayed sitting. Another young woman, non-weight bearing with cerebral palsy, could not swallow, and so she was on tube feeding. She ended up with a fracture in her upper arm. I was suspicious that she had vitamin D deficiency, and the doctor didn't think so, thought somebody was just too vigorous in transferring her. Said, well, she's got vitamin D in her tube feeding, which she did, but she also was on seizure meds. And about 6 months later, she got a fracture in one of her lower leg bones. And at that point, the doctor conceded maybe we needed to check a vitamin D level, which it was abominably low. So she now gets vitamin D liquid supplement as well as just the typical amount of vitamin D that's in a tube feeding. So here's the treatment: adequate vitamin D and calcium. 1,200 milligrams calcium a day, 800 to 1,000 international units of vitamin D in general. Food sources: spinach, milk, salmon, yogurt, ice cream. Yay, ice cream. Exercise. If someone has osteoporosis, that you do want them to gently move, but you don't want to overdo it because their bones are very vulnerable to fracture. Weight bearing and balance exercises are important, but when they're doing balance exercises, make sure that they're not putting themselves at risk to fall. I just want to tell you, because I often hear people say, well, we get vitamin D from the sun. Why do we need to take supplements? Why do we need to be so aware? But if you are of a mind to go out naked every day of the year in the sun, or well, today we have sun, but how many days have we had sun lately? You will still never get enough vitamin D from the sun in this climate. So you just got to accept it. You have to eat food sources with vitamin D, and very likely you're going to need a supplement as well. So what do we do about osteoporosis as far as treatment? As I already mentioned, prevent falls. And you can see assistive gait devices, home safety assessment to make sure there's nothing that's going to get in the way and cause a fall, or if they need things like grab bars and railings. Well-fitting shoes. A person can have fractures in their feet if their shoes aren't fitting well, and they can fall if their shoes aren't fitting well. standby assist while ambulating. And then there are meds prescribed for osteoporosis. They won't fix it for sure, but they can help some. And they have their own risks of side effects. Alendronate is the pill you would take. There's also IV, and you can also have injections and pain medications as prescribed. Edema, fluid, swelling, fluid trapped in the tissue, hands, feet, ankles, legs. It can be caused by serious things like heart failure, kidney disease, or liver disease. But the most common thing that adds to the problem is if you're sitting a lot with your legs bent at the knees. Signs and symptoms, here they are. Swelling, pitting of the skin, reluctance to do activities, increased weight gain. Could be because a person's not as active, but more typically it's from the fluid buildup. And pain, it's a pressure pain against the skin. Treatment, compression stockings. Oh, I know, they're not fun to put on, and many people balk at having them. They really do work though. Elevating limbs, you may get a buy-in with putting the feet up more than you do with the compression stockings. And it can help a lot, just having the legs straight. And medications prescribed by the doctor, such as a diuretic, which is a water pill. Warning, it makes you go pee with more frequency and with a lot more urgency. So this is a pill that people, if they're taking their pills on their own, may kind of forget to take because they don't want to wet themselves. I'll give an example of an individual who had horrible edema in her legs, so much so that the fluid had broken through the skin in many places. She had open sores all over. She was over 300 pounds, which didn't help. She sat in a chair all day, and as I found out later, all night, with her legs bent at the knee and her feet down on the floor. And over time, with agreement, she got a recliner with a footrest that went up. She got a bed she was finally willing to sleep in. She had treatments, wraps, and a diuretic she finally agreed to take, and those wounds healed. But it was a very big concerted effort by her team and by her finally being motivated. Pressure ulcers. I don't expect you to be a nurse. I'm just showing you these levels and these stages so that you know how bad a pressure ulcer can get, from a red spot, which is when I'm hoping you're going to see it, all the way down to the bone. And when you get infection in the bone, it's IV medications for sometimes months, and it doesn't go away easily. Where do you see pressure ulcers? Well, in the spots where you have a bony prominence. You can see them all right there. So look, watch for red areas. Next month, I'll be doing a webinar called Save My Skin, and we'll go into more detail about this. But here it is in a kernel of wisdom. The reddened area doesn't go away. Document it, report it, and remove the cause of the pressure. None of the fancy dressings and getting somebody healed are going to be worth anything if they continue to have pressure there. It'll reopen. Sores and rashes. These can occur due to infection from bug bites, heat, allergies, poor hygiene, disease processes. You can see a picture here of an itchy rash, and the person scratched it until it came open. Skin breakdown in the groin area from incontinence is also common. So signs and behaviors: scratching, restlessness, sleep changes, refusing to sit or lie down, heat, fever, and redness. Be aware. This can happen, and if you're not checking a person's skin, it can happen and you're not aware, and it goes from itchy to scratching to a spot that's open to picking an open spot. What do you do about it? Well, first of all, for the pressure ulcers, relieving the pressure, which I talked about, using pillows and cushions. For all of them, providing good hydration and nutrition, and using padded foot and arm rests. What else? Maintain clean, dry skin. Provide good hygiene. Check skin in commonly affected areas daily. I'd like to put that in bold and maybe in neon. Notify a doctor and follow wound care orders and prescribe medications when necessary. I'm going to go back and say one other thing. If somebody has a rash, you want to do some detective work to figure out where it is and what might be rubbing against that skin or touching that skin. Sometimes it's from a new detergent or a new soap. Okay, hemorrhoids. When I first taught this class, I didn't have anything about hemorrhoids until somebody came to me and said, do you know what a pain, you know where hemorrhoids are? They're inflamed, swollen veins in the rectum and the anus that can cause significant pain, itching, and bleeding. Obesity, aging, diarrhea, and constipation are all the risk factors, and constipation is a very big risk factor. Here you see the signs. So sometimes things are ignored until you have the red blood in the stool. There is ointment. You've probably heard of preparation H. There's medicated wipes. There's soaking. You can use a sitz bath like I have a picture of on this slide. Also wet wipes after a BM to kind of soothe and completely clean. There are medications for pain. Then there are some procedures, a banding, which is like putting a rubber band around it to close off the blood flow, or surgical removal. Please be aware, surgical removal is what we'd like to prevent. If it's needed, it's needed, but it is quite a challenge with pain afterwards. UTIs, another source of pain. Possible causes, urinary retention, catheterization, obesity, diabetes is a really, really high risk factor. Aging also, constipation, and poor hygiene. So if somebody is having challenges, they have one, that's bad enough, but if they have another one, you need to be looking at what risk factors you can eliminate from these causes. Symptoms, you may all know these: increased frequency or urgency of voiding, a change in a void pattern, a difficult void, burning or pain. Now I will say it's good actually if a person is feeling that burning or pain, because they may show some evidence then of feeling that pain. As a person ages, or if they have diabetes, they often lose that sensation of the burning or pain. If a person is incontinent at night and they haven't been before, that can be a sign. Changes in behavior or awareness is a very common sign. In fact, if I have a call about somebody who suddenly is confused, I will ask that they check for a bladder infection by having a urine sample taken in and checked. Fever or cloudy, foul-smelling, or blood-tinged urine. Treatment. Good perineal hygiene, adequate fluids. Notify a doctor for antibiotics or other treatments that might be needed. I will say that the hygiene issue can be kind of tricky, but the basic thing is wipe from front to back for women. However, Lucy kept telling me she was wiping from front to back, but she kept getting bladder infections, UTIs. So finally she agreed to let me watch her while she wiped in her bathroom, she and I, and sure enough, she wiped from front to back to front. What she was doing was wiping front to back to front. And so, of course, that defeated the purpose. We developed a little song for her to sing that she wiped from front to back and dropped it now. And she didn't have any more bladder infections. So we do have to be good detectives to try to figure out what might be going on. And fluids, at least 64 ounces of fluids a day for most people. Spasms and cramping are painful muscle contractions, sudden, uncontrollable, and here you have a list of causes: imbalance of minerals and nutrients, fatigue, low oxygen, menstruation, quadriplegia, that's being paralyzed in 4 limbs, cerebral palsy. We often call them Charlie horses. Most people have had at least one of them. You can have a uterus cramp, a bladder cramp, a colon cramp. And here are the signs: being less active, rubbing or holding an area, restlessness, lethargy or agitation, changes, again, changes from typical behavior. So what can be done? Here you have a list: massaging, stretching, over-the-counter treatment, heat, proper hydration and nutrition, and medications as ordered per physician. Some women have such terrible menstrual cramps that they take birth control pills or have other means of birth control to prevent this happening. Okay, we're a little behind because we're slow getting everything figured out. But here are the 4 situations. We'll start with number 1 that we talked about so that you can be a detective and figure out possible pain. So this is Joe. He used to eat, enjoyed his eating, but for the last week, he has not been eating all of his meals, not even pizza, which is his favorite. And sometimes he's been coughing as well. So what are possible causes of Joe's problem? Do you all have some ideas? Has anybody entered any ideas? I know we're kind of short on time. So I'm just going to go ahead and see if you have thought of these. So here's a list. Were those the ones that you were thinking of? Any of those could be possible. The next one, Sally has been hitting her head with her hand and hitting her head against furniture or walls. Note, this has not been a typical behavior for Sally in the past. I pointed that out because we have some people that consistently have this kind of challenging behavior as their baseline. So what are some possible causes of Sally's behavior? You ready? Have you figured it out? Here they are. Headaches, ear pressure, infection, wax buildup in the ears, mouth pain, or whole body pain, or a UTI, because it's a change, right? Number 3, Agnes. She has been walking with a walker, but now she's having problems and resistance. She gets agitated, she cries, she doesn't want to get up out of her wheelchair when usually she's been calm and smiley. What are the possible causes? Could be fractures of any of these: vertebrae, leg, ankle, foot, or shoulder. Because think about it, if you have shoulder fracture, are you going to want somebody assisting you with transfers? And are you going to want to be holding on to a walker? Or arthritis pain in her joints. And number 4, Tina. She's usually happy and cooperative and willing. But once a month for a few days, she's agitated, yelling, striking out, and refuses to participate. What are some possible causes for Tina's behavior changes? And as you may have surmised, because of that being once a month, you would think that would be quickly caught on to, but I can tell you, working with people such as Tina, staff just aren't noticing the consistency of this. And so menstrual cramps and pain, as you might surmise, or hormone changes that are affecting her mood and feelings. I just want to say that we hope this webinar will help you to always consider whether pain is a factor for any changes in a person's behavior. Sometimes we assume it's a change in a caregiver, and it might be, but it could be pain. So look for clues to help you understand what could be happening and to realize what the next steps should be. And thank you for watching.